So just to briefly summarise the current treatments that we have available in pulmonary arterial hypertension, we have the agents that either try and increase those factors that promote vasodilatation, and these are the PDE5 inhibitors, agents such as sildenafil, as well as the prostacyclin derivatives, as well as those agents that are designed to limit the production of agents that cause vasoconstriction, such as endothelin. So we have the endothelin receptor antagonists. The three newer agents I'd like to discuss are firstly the new dual endothelin receptor antagonist, Maccitentan. Talk about the soluble guanylate cyclase inhibitor, Riociguat, and then talk about Selexipag, which is a new prostacyclin receptor agonist. And what I'd like to do with each of those agents is to discuss briefly their randomised data, but also talk about our local, albeit limited, experience with these agents. So as mentioned, Maccitentan is a dual endothelin receptor antagonist. It is more potent than the currently available ERAs, in particular bosentan and ambrisentan. It offers single daily dosing, again in comparison to the twice daily dosing of bosentan. And its seminal trial was the Seraphim study, which was an event-driven study published in the last 6 to 12 months. As mentioned earlier, this was a relatively unique study in that in the past, pulmonary hypertension drugs had been studying using things like 6-minute walk test and assessment of hemodynamics. So this shows the composite endpoint of a combination of death, need for transplantation, change to intravenous prostacyclin, or worsening pulmonary arterial hypertension. And so you can see that certainly compared to placebo, over 3 years of follow-up, Maccitentan offered an advantage with this composite endpoint. And I think when you look at those endpoints in detail, much of this was driven by reducing worsening of pulmonary hypertension. It didn't appear to have a significant impact on death, need for transplantation, or need to commence intravenous prostacyclins, but nonetheless, worsening of pulmonary arterial hypertension and need for hospitalisation was certainly a pleasing result. Now, whenever anyone looks at the randomised studies with the adverse events, there's always a number of them. But there's one I'd just like to highlight in detail, and that's the presence of peripheral edema. And in this clinical, or in the randomised study I should say, there didn't appear to be any difference compared to placebo. And I'd just like you to keep that point in mind. Certainly, as has been already mentioned, this was one of the limitations of bosentan. So the conclusions in the New England Journal paper when it was published, that this newer agent reduced morbidity and mortality amongst patients with pulmonary arterial hypertension. And it appeared to be without any penalty in terms of liver function tests or in terms of the presence of edema. And the one thing I think is worth noting, certainly when we looked at our own experience, is that the mean age in this population was 45 years. So I'd just like to discuss briefly the John Hunter experience with this medication. So I acknowledge at the outset this was our initial experience and was somewhat limited in terms of numbers. But nonetheless, this agent was made available, and therefore we trialled it on a number of patients. When we look back with the benefit of hindsight, the average age of our patients was 65 years compared to the 45 years seen in the study population. We had a much more complex patient population with significantly advanced disease. And when we looked at the average 6-minute walk test of our patient population versus the study population, there was almost a 200 metre difference. And again, when we looked at these were patients who were failing bosentan or sildenafil or in combination, or who for one reason or another were intolerant of the currently available agents. And our experience was actually quite poor, in that patients had trouble with symptomatic hypotension, almost certainly reflecting the increased potency of this drug, as well as difficulty with pulmonary edema and worsening left heart failure, presumably due to a degree of fluid retention. And so my interpretation is that whilst this medication certainly has a role in the younger patient, extend caution in the older patient, the patient who has advanced disease, the patient who has low blood pressure, or the patient who's prone to fluid retention. I do think this medication has an important role, and certainly in the younger patients whom we commenced on this agent, they've certainly had a significant benefit. Just to turn our attention now to Riociguat, which is a novel target for the treatment of pulmonary hypertension compared to our existing agents. There were two main studies looking at this, looking at patients who had pulmonary arterial hypertension, but also patients who had chronic thromboembolic pulmonary hypertension. And I'll touch briefly on both of those studies. The studies of Riociguat were a throwback to the older days of looking at hemodynamics and 6-minute walk test. And at 12 weeks, Riociguat certainly improved 6-minute walk test and pulmonary vascular resistance in patients with pulmonary arterial hypertension. The one thing that's worth noting when you look at the baseline characteristics of these patients is that almost 50% of them were already on some form of baseline pulmonary hypertension treatment. In the vast majority of these were endothelin receptor antagonists. And so certainly in Australia, where patients are not reimbursed for multiple medications, and given the cost of these agents, I think that's an important consideration, that in almost the majority of the patients, this was used as add-on therapy, not as monotherapy. But again, the graph shows quite nicely the improvement in 6-minute walk distance. I haven't included the hemodynamic graphs, but they certainly move in a similar direction. This is just to show that this medication was quite well tolerated, and it was clearly not powered for clinical events, but there doesn't seem to be a signal at this early stage of any harm with this novel agent. And so this was the conclusion, that this agent significantly improved exercise capacity and the secondary efficacy endpoints in patients with pulmonary arterial hypertension. But as I said, this study wasn't powered to detect clinical endpoints, and so I think to extrapolate that is probably not fair. And as I said, I think at this stage is probably limited to an add-on medication. But having said that, that's not to say this medication is not without an important clinical role. Because the second component, as I said, was in patients with chronic thromboembolic pulmonary hypertension. Now, in the past, we've used endothelin receptor antagonists in an off-label fashion because there has been some signal that perhaps patients with chronic thromboembolic pulmonary hypertension do derive some benefit from Maccitentan therapy. But the reality is that it's not ideal for that agent. The ideal treatment for chronic thromboembolic pulmonary hypertension is pulmonary endarterectomy. But I think there's certainly limited experience worldwide, and certainly in Australia, with patients having with surgeons having relatively limited experience. And so therefore there is an unmet need for medical therapy for this condition. And so, as I said, Riociguat was used in this patient population. The vast majority of patients were considered inoperable in terms of pulmonary endarterectomy. And I think that probably reflects the majority of patients we see in clinical practice. We only have very few patients who have been referred and have actually undergone pulmonary endarterectomy. But again, this study also included a quarter of patients who had undergone previous surgery who had residual pulmonary artery hypertension. And again, the graph is not dissimilar to the graph I showed with the pulmonary arterial hypertension group, showing an improvement in 6-minute walk distance over the 16 weeks of study. I think the thing that's dramatic about this is the fact that there's actually a decline in the patients who are treated with placebo, demonstrating that this is such an aggressive disease. Although it is of interest that patients did derive initial benefit, presumably reflecting a placebo effect. And so this was a conclusion in the New England Journal paper. The Riociguat improved exercise capacity in patients with chronic thromboembolic pulmonary hypertension. Now again, our experience with this agent is somewhat limited. We've used it as add-on therapy in a number of patients who have deteriorating effort tolerance and worsening symptoms with pulmonary arterial hypertension on existing therapy. We've also used it in patients with chronic thromboembolic pulmonary hypertension, both as monotherapy as well as add-on therapy. One of the limitations of this agent is it requires an up-titration process from 0.5 milligrams TDS with half milligram increments to 2.5 milligrams TDS, which is potentially complicated and at times time consuming, especially if patients are from distance. And I think Dr. Bagwandeen showed earlier today the distance that some of our patients have to travel. The other issue is that 3 times daily dosing is clearly inconvenient for our patients. But the other issue that limits this up-titration process is blood pressure. So this medication does have an effect on the systemic blood pressure and can certainly limit the ideal up-titration, getting to that dose of 2.5 milligrams TDS. And that issue of up-titration is something that we'll come to when talking about Selexipag as well. So the last study I'd like to mention briefly is Selexipag, and this again is a novel target for the treatment of pulmonary arterial hypertension. And this is an oral prostacyclin receptor agonist. So this looked at the phase 3 study has not yet been published, but I will mention it, but certainly met its primary endpoint in its randomised phase 2 study looking at pulmonary vascular resistance. So again, a purely hemodynamic study. So based on the phase 2 study, they proceeded to a phase 3 study looking at clinical endpoints. And as I said, the study in its entirety has not yet been published. The aim was to evaluate the longer-term efficacy, safety and tolerability of this agent. And I must say, in this Griffin study is our only experience of the John Hunter Hospital. This agent has not been made available in Australia in any way, shape or form, but we did have a number of patients involved in the Griffin study. And so at this stage we've had no real-world exposure, and as I said, the clinical paper is yet to be published. As mentioned, this was a clinically driven endpoint study. The Griffin phase 3 study was a clinical endpoint study looking at a reasonable number of important clinical endpoints, whether they be disease progression, hospitalisation, the need for additional therapies or need for transplantation or septostomy or death. And so again, the outcomes were stratified according to patients' baseline characteristics, depending on whether they were functional class 2 or 3 versus 3 or 4. The main secondary endpoints were those anticipated endpoints looking at things like 6-minute walk test distance, as well as worsening the patient's functional capacity. Also looking at issues of safety and tolerability. Now, as I mentioned with Riociguat, one of the difficulties in commencing therapy is this prolonged up-titration process. But this was significantly more problematic in the Griffin study. So there was weekly up-titration over 12 weeks, aiming for a maximum dose of 1600 milligrams BID. And again, I can anticipate this being a problem when we commence patients on Selexipag, this issue of progressive up-titration. As Dr. Basham mentioned when we were discussing intravenous prostacyclin earlier, there does tend to be a degree of tachyphylaxis. So patients get used to these medications needing up-titration. But nonetheless, up-titration can be limited by things like headache, flushing and hypotension with Selexipag in much the same way this limits the up-titration process of intravenous prostacyclins. Just to touch briefly on the baseline characteristics, this was again a younger cohort of patients, which was predominantly female. Interestingly, more than half of the patients had functional class 2 or 3, so these were patients with quite advanced disease. But only 20% of patients were treatment naive. So again, in 80% of this patient population, this was used as add-on therapy. I think this is the way future studies are going to go, because I think it's going to be very difficult to randomise against placebo, because I think many ethics committees now would consider that unethical. So this is the primary endpoint, which is time to the first morbidity as mentioned, or mortality. And again, over a course of 3 years, there seems to be an advantage for Selexipag compared to placebo. Again, I would emphasise that we still have to wait for the full publication of the clinical paper, and this has only been really presented in abstract form. Nonetheless, though, the conclusions when presented were that Selexipag reduced morbidity and mortality by up to 40% in patients with pulmonary arterial hypertension. And interestingly, when you do look at the the available data in a bit more detail, the benefits seem to be both in patients who are treatment naive as well as in add-on therapy. There is this issue of individualised up titration. I think this is potentially going to be problematic when we see this agent introduced into the clinical realm. And it appears that it was well tolerated, with similar side effects to those seen with oral, subcutaneous or intravenous prostacyclin agents. So I guess to summarise, we do have newer agents for pulmonary arterial hypertension, and pleasingly some of these are novel targets rather than just extension of our current armamentarium. I think the role, however, is a little bit unclear. It's not clear whether any one of these agents is going to be ideal as monotherapy. It's going to be difficult to assess which patients should be considered for add-on therapy, and in which case, which agent. Certainly in Australia, as I mentioned, we're reimbursed for monotherapy, but not for dual or triple therapy. And at this stage, sildenafil is by far the most inexpensive option. And so, as I said, I think it's going to be difficult to see where some of these agents, where in their clinical trials were used predominantly as add-on therapy, where they're going to fit into our clinical use. And so with that,